Shock advised. Stand clear. Push shock button.
Redfield, that's attack priority 1.
Ladies and gentlemen, boys and girls, NBs, they, thems, and whoever the three people watching my videos are, welcome back to another video. So this is going to continue my lectures on shock and hemodynamics. Last lecture we talked about cardiac output. In the one previous to that, we talked about what shock actually is. So now we're going to get into fun stuff. We're going to get into oxygen delivery, consumption of oxygen, and gas exchange. So remember this DO2 versus this VO2, right? Because, I mean, at the end of the day, like I've been saying, what is shock? Well, shock is when the supply of oxygen is less than the demand for oxygen, right? That's all shock is. At the end of the day, it's just the different things that cause it. Okay. Moving on. So in this module, we're going to be learning about oxygen delivery dynamics and how they influence shock states. We're going to be talking about the oxyhemoglobin dissociation curve. I know you guys are super excited about that. And then we're going to be talking about gas exchange at the cellular level. And then at the very end, for the people that want to stick around, we're going to do a review of everything that we've covered so far in the last 3 videos. So let's get into it. Okay, DO2 versus VO2. Remember, your body is not like the American economy. It actually does adhere to the law of supply and demand. So, like I already wrote, but I'm going to write it again. Shock is when the supply of oxygen is less than the demand for oxygen, because your body likes to have a happy medium. And in shock, it's not in a happy medium. It's very upset because it's not getting the oxygen that it needs. So here's a diagram, right? So let's start at the right side of the heart here, and then we'll loop our way back. Okay, so right side of your heart, it pumps blood to your lungs. Those deoxygenated blood cells are going to pick up some oxygen. They're going to go through the lungs into the left side of the heart, and it's going to be pumped out into the systemic circulation. This is your DO2. Right? So that's your supply. It's going to go all the way around, and then it gets to your tissues, and then your tissues are the VO2. So this is the demand, right? So we got supply up here, and then we got demand down here. And in shock is when DO2 less than VO2. Okay, and then from here, your tissues are going to extract the oxygen. They're going to dump off that CO2. It's going to go all the way back into the right side of your heart. And then the loop starts again. Okay. I know that this was drawn in Microsoft Paint. I created it myself because I love all of the 3 people that are watching my videos. Okay. So, oxygen delivery, DO2. This is the supply chain, right? So DO2 equals supply. So the definition of DO2 is it's the amount of oxygen delivered to the tissues in 1 minute. There are 2 things that make this up, okay? The average range for a normal person is about 640 to 1400 mils per minute, and DO2 is made up of cardiac output times arterial oxygen content. Okay, so let's do this, and then we'll talk about what we can do about it. So another way of writing this would be DO2 equals heart rate times stroke volume times our arterial oxygen content, right? And we already know that we can alter the rate, so we can raise the rate or we can lower the rate. And we got preload, afterload, contractility. So preload, P-load, A-load, contractility. So remember, if we want to increase our preload, we can give them fluids. So like increase would be fluids. If we wanted to decrease, we could give them like diuretics. If we wanted to increase our afterload, we could give them pressors. We could give them, like if they had high afterload, we could maybe put them on like a nicardipine drip. Nicardipine. And if we wanted to alter our contractility and we wanted to increase it, that's our inotropes, positive inotropes. And if we wanted to lower it, we could maybe do like a beta blocker or something like that. So this is one side of the equation. Now we're going to get into the other side. So remember, to improve delivery, we have two options. We can either increase our heart rate or our stroke volume, or we can increase the content of our arterial oxygen content. Remember, like say that a product from Walmart is in high demand. In order to maintain American consumerism, they can either increase how often shipments are coming through altering this part, your cardiac output, or they can, stack the truck full and put everything on one truck at once, and then that would be altering the arterial oxygen content. Okay, are we clear on that? Okay, good. Okay, so this is our CaO2, okay? So arterial oxygen content, CaO2. Okay, this is the cargo, right? So let's say that Walmart has increased the amount of trucks and the frequency and how often they're coming, but now that product is still in high demand, so now they're going to have to start stocking the trucks even more full than they already are. I doubt that they're going to pay you anymore for, unloading a big truck, but, labor rights and all that, right? All right, so this is the formula for our arterial oxygen content, okay? So we got CaO2 equals hemoglobin times 1.39 times our SpO2 plus 0.0031 times PaO2, which is our partial pressure of oxygen. This is the dissolved part of oxygen in your bloodstream. So partial pressure of O2. Okay. So the bus analogy. All right. So we got hemoglobin. This is the bus. This is what's taken, all those oxygen molecules around to the tissues that need them. Okay, so hemoglobin is a protein that has a lot in you have a lot of hemoglobin in these blood cells. That's why they don't have a nucleus. They eject the nucleus so that they can make more room for hemoglobin. It has a central iron atom in the ferrous state. What does that mean? It means that it has been reduced and it is positive. You don't need to know this. And then oxygen is going to bind to that central atom through some complicated electron shenanigans in chemistry. It's basically magic. Okay, so that's the hemoglobin part, right? And then we got our saturation over here. So our saturation is how full the bus is. So if your hemoglobin is 97% saturated, that means that 97% of the hemoglobins in this blood cell will have an oxygen attached to them. Okay. And then we got our partial pressure of oxygen. This is like the dissolved oxygen molecules in your bloodstream. So they're not attached to hemoglobin. This is like people running alongside the bus. Okay. So do note that math and all this, like I said, you don't need to know this, but you do need to understand it. So this factor that we're multiplying our partial pressure of oxygen is 0.0031. That is a negligible amount compared to hemoglobin. This number is going to be a lot bigger than this one, right? So you can increase this to like 200 and it's not really going to make that big of a difference in the grand scheme of things. This over here is what matters. Now, why does this matter? Well, using the bus analogy, let's say that your body is the president and really hates the idea of public transit, and it's going to eject all this hemoglobin out your bunghole in the form of a GI bleed. Well, you can have like a hemoglobin of 3 and 97% of those are, saturated with oxygen. But in the grand scheme of things, it's not really going to, enhance oxygen delivery, and the oxygen delivery to your tissues is not going to be enough. Okay, moving on. Okay, So this is what hemoglobin actually kind of looks like. Again, you get another wonderful drawing in Microsoft Paint from yours truly. So this is deoxyhemoglobin, right? There's this central iron atom in the middle. It's not attached to anything, but it sure would like to be. So you got all these oxygens hanging out here, and these oxygens are going to bind to that central iron atom. Okay, now let's go back to the formula for our DO2, right? So DO2 equals cardiac output times CaO2, which is that arterial oxygen content. Now, if we really wanted to expand on that, we could say that DO2 equals heart rate times stroke volume times hemoglobin times 1.39 times SpO2 plus, my goodness, 0.0031 times the partial pressure of oxygen. All right, so this is the broken down oxygen supply equation, right? So we can alter our heart rate, we can increase or decrease our heart rate. Remember, preload, afterload, contractility. So P, A, and C. We can increase this, we can decrease this, we can increase this, we can decrease this, we can increase this, and we can decrease this. So for hemoglobin, you know, like I said, if all your hemoglobin has fallen out of your butt because you are bleeding out of it, we can give you a transfusion, right? So we can increase this, or if you're hypoxic, we can increase this, and that would also increase the partial pressure of oxygen. So this is the expanded supply of oxygen equation. You don't need to know this, but you do need to understand why it is important and how it actually works, because when we're trying to, you know, treat someone who's in a shock state, we can basically, you know, manipulate any one of these parameters, right? Okay, moving on. All right, let's talk about oxygen consumption, right? So this is the demand. So in shock, again, our DO2 less than our VO2. Okay, so what am I doing? Oxygen consumption, this is the demand. So the amount of oxygen is actually extracted by the tissues, right? So normal range for this is 180 to 280 mils per minute. Now, our oxygen extraction ratio, this is how much oxygen our tissues are actually using compared to how much is being delivered. Normally, when we're healthy, our oxygen extraction ratio is about 25%. That means that if we're sending 100 molecules of hemoglobin or whatever, we will have 75 left over. This is called the reserve. Now, if you've ever heard about a patient having like a low reserve, like a low or a chronic COPD who just doesn't breathe super well, and as soon as they take their oxygen off, their oxygen saturations and stuff like that plummet. Well, this is why. This is the reserve. So they'll have low reserve. It might be like 50%. So yeah, that's what the reserve is. Okay. And in shock, right? Again, shock, supply less than demand. Now, if in profound shock, if our DO2 or our supply drops below a critical point, the tissues can't extract enough to survive, and they're going to switch it over into that anaerobic metabolism, which is going to give you lactic acid and a meager 2 ATP. Okay. Clear as mud. Moving on. Okay. Another hemodynamic value that we need to know, it's our mixed venous oxygen saturation. If it's measured in the PA catheter, remember you got that Swan Gans with the balloon measuring all that in your PaOP. Well, you can also float it up and you can get the mixed venous oxygen saturation from the pulmonary artery, and that's your SVO2. So PA is SVO2. Or you can measure it through a central line, and that would be, like your CVP and your RAP. But if you measure the mixed venous oxygen saturation through a central line, that is called the SCVO2. SCVO2. Remember, there's a C in here for central line. Okay, so this is measuring our reserve. Okay, so a normal is 60 to 80%. Remember, your tissues use about 25%. So if it's low, if this number is low and you don't have like a high reserve, or your reserve isn't where it should be, it means your tissues are probably hungry. I mean, it can be caused by a low supply, like anemia, hypoxia, or low cardiac output, or it can be caused by high demand, like fever, pain, shivering, which would be, like your sepsis. Well, in the early stages anyway. Now, a high mixed venous oxygen saturation means that your tissues can't eat, and that can be due to a variety of causes. This would be like mitochondrial dysfunction. This can be caused by sepsis, just know that. It can be caused by cyanide toxicity, which prevents your mitochondria from actually even using oxygen. Or it could be some kind of shunt, like the blood is just not going to where it should be, so it's not getting used up. Alright, remember, mixed venous oxygen saturation, if it's measured via PA catheter, that's our SVO2. If it's measured via central line, that's our SCVO2. Okay, now we're really gonna get into it here. So pop a Zen or have an energy drink or do whatever you need to, because this is gonna get dense. Okay, we're gonna talk about the oxyhemoglobin dissociation curve and gas exchange now. So we know why our body needs oxygen, right? We know how the oxygen gets there through cardiac output, and how hemoglobin and stuff like that works. Now we're really going to get into the weeds here. Okay, this is the oxyhemoglobin dissociation curve. You've probably seen a picture of it. I don't know if you've ever really recognized what it means. Okay, so let's see here. So you have this S-shaped curve. This blue line in the middle is where you should be. Now there are conditions that can cause it to shift to the left, and there are conditions that can cause it to shift to the right. Now, let's talk about left shift here first. Left shift. All right. Left shift. This is a new relationship, right? Hemoglobin is super clingy to oxygen, super protective. It does not want to get rid of it. Maybe they're on a glorious Icelandic vacation because they're really cold, so they stay warm by cuddling together. They really don't want to let go of each other, right? Maybe it's the oxygen's ex-girlfriend, 2,3-DPG, which is 2,3-diphosphoglycerate, just went to prison, so hemoglobin doesn't have to worry about getting jealous anymore. Or maybe the environment they're in is very alkaline, so they stick together. So a left shift means there is more love between O2 and hemoglobin. They love each other. They don't want to separate, okay? Now, what this practically means is that at the same pressure of oxygen, you're going to get less oxygen released. And again, this can be caused by an increase in pH, decreased levels of 2,3-DPG, or diphosphoglycerate, or a low temp. Now, what is 2,3-DPG? Well, it's 2,3-diphosphoglycerate, and all it does is it alters hemoglobin a little bit. So when there's decreased levels of 2,3-DPG, hemoglobin is more likely to hang on to oxygen. Now let's talk about a right shift. Right shift means that, oxygen and hemoglobin have been married for like 20 years. They're super unhappy with each other, and they're just looking for any reason to split. Maybe it's because, you know, the environment they're in is super acidic, so the pH is low, right? Maybe 2,3-DPG is back in the picture. He just slid into Oxygen's DMs. They're hanging out now. And, you know, hemoglobin is just like ready to get it over with and split up. So increase 2,3-DPG. Or maybe, you know, they're on a vacation somewhere. It's super hot. You know, they don't want to be around each other because, like, they're just, anytime that they're cuddling, it's just miserable. And they want to not be around each other. So that's increased temp. Now, let's talk about 2,3-DPG again for a second. So if someone's like anemic, their body will release 2,3-DPG so that hemoglobin will more readily ditch oxygen. So anemia or altitude. So higher altitudes, your body will release more 2,3-DPG so that hemoglobin has less affinity or less love for oxygen. So right shift means that they hate each other. They want to get rid of each other. Hate each other. Other. And a left shift means that they love each other. Okay? Now, we're going to talk about the Bohr effect in the next slide. Next slide, we're going to get into gas exchange, and it's going to be dense, so I'm sorry in advance, but, you know, what can you do about it? All right. Gas exchange at the tissues. I lied. All right. Gas exchange at the tissues. Okay. Let's get into this. This is going to be kind of dense. Keep in mind, you don't need to know every single step, but I do want you to at least understand how this works and how different things are going to interact with each other. Holy crap, that is a mess, isn't it? Now, let's break it down here. Okay. Let's move this out of the way. Okay. So remember from the very, very first lecture, right? How does our body use oxygen? Okay, well, it uses oxygen to break down glucose so that you can get ATP, right? So remember what that formula is. It's C6H12O6 plus 6O2, and that is going to react, and you're going to get 6CO2 plus 6H2O plus 32 to 38 ATP. Okay. Now, this is oxygenated blood going into the capillary. So just for the sake of, you know, our own sanity, let's just say that it's going that way. And then it's going to drop off its oxygen, and then it's going to go to the lungs and all that good stuff. But let's talk about this. Okay. So some of this waste product CO2 is going to go into the bloodstream, and it's going to be dissolved, and it's just going to be transported as CO2. This is not a lot of it. It's like 3-ish%. Some of it is going to bind to the hemoglobin, and it's going to become this carbonated hemoglobin molecule. This is like 7%. But most of it, like 90-ish%, is going to be converted into carbonic acid, which is then going to be converted to bicarbonate ions. And this, I'll draw it on this one over here. This is the Bohr effect over here. Okay, so let's talk about this. Okay, so remember, like most or some of your CO2, like 3%, is going to just get dissolved in the bloodstream, and it's going to be transported as itself, right? Some of it is going to come in here, and it's going to be converted into that carbonated hemoglobin. So CO2 plus HB gets you your HbCO2. But most of it by and large, is going to be transported as carbonic acid. And we will get into this. All right. So blood cells are, passing through. They're going to pick up all the waste products from aerobic cellular respiration. So you're going to get CO2 plus water. And then these are going to react with an enzyme called carbonic anhydrase. So CAH. And that carbonic anhydrase is going to combine these two together, and you're going to get carbonic acid, which is H2CO3. Now, your body is like, hey man, what's going on? And then a chloride ion is going to get exchanged. It's going to come in here, and it's going to live here. So Cl minus. And then a hydrogen ion is going to fall off. And remember, all acid is hydrogen ions. So we got an H plus ion over here. And then this now bicarbonate ion, HCO3 minus, is going to probably combine with a sodium ion extracellularly. Okay, so what do we got going on here so far? We have a CO2 and a water. They're coming into the blood cell here. They're going to be added together by carbonic anhydrase to form carbonic acid. This carbonic acid is going to be broken down into bicarbonate, and it's going to leave behind a hydrogen ion. Because your cell likes balance and charge, this chloride ion that's hanging out here is going to come in here and hang out to balance these charges out. Now, once that happens, we have HbO2. This is our carboxyhemoglobin, right? So we got oxygen bound to hemoglobin right here. And then some funky stuff is going to happen. And then this hydrogen ion that the carbonic acid left behind is going to come down here, and it's going to combine with hemoglobin. And once that happens, our hemoglobin is going to ditch that oxygen molecule so that it can come down here and perfuse your tissues. Now, let's talk about like the Bohr effect, right? So if there's more CO2 up here, that means that there's going to be more hydrogen ions over here, which is going to lower your pH. And if your pH is lowered, well, guess what? Think about it. Your hemoglobin is really going to want to get rid of that oxygen molecule so that it can take this hydrogen ion and transport it back up to the lungs to get rid of it. Okay, so this carbonic, all right, so we have CO2, we have water. It's going to come down here into the blood cell. Through carbonic anhydrase, it's going to form carbonic acid. This is going to be broken down further. This carbonic acid is going to leave behind a hydrogen ion. It's going to go out here into the extracellular fluid and or the plasma. Because your cell likes to have charges balanced, a chloride ion is going to come in here. And then we got our carboxyhemoglobin over here. This hydrogen ion that got left behind is going to combine with hemoglobin, which is going to ditch your oxygen molecule over here. Like I said, you don't need to know this, but I do kind of at least want you to understand why, having a low pH or an excessive amount of carbon dioxide is going to cause a lot of hydrogen ions, which is going to readily ditch oxygen in hemoglobin, causing a what shift on the oxyhemoglobin dissociation curve? That's right, a right shift. Okay, now this blood cell and this blood cell over here are going to go that way, and they're going to go back up to the lungs. So gas exchange at the lungs. All right, let's get into this one. Okay, so it's basically the same thing that we just went through, except it's in reverse. Okay, so, remember, we got 3% of our CO2 is just out here kind of hanging out in the bloodstream. It's just going to diffuse across the alveoli. We got a little bit of CO2 in that carbonated hemoglobin form. This is going to break up. It's going to leave behind a hemoglobin and a CO2, and then it's going to cross diffuse over that alveoli. Now, we got this bicarbonate ion that was hanging out that ditched from the blood cell. But now this bicarbonate ion is going to go back into the blood cell. And because remember, your cells like to be charge balanced, this chloride ion is going to leave. Now, in the cell, it's going to get turned back into carbonic acid. And then that carbonic anhydrase enzyme is going to leave behind a CO2 and water, which is going to diffuse across the alveolar membrane. Now, how does this bicarbonate ion become carbonic acid again? Well, my friend, you see, when oxygen is in the lungs, it's like, hey, why is this hydrogen attached to my hemoglobin? And they're going to recombine, forming this oxyhemoglobin molecule, which ditches this hydrogen ion, which is able to form that carbonic acid. Okay, now let's draw it over here so we can go step by step. So remember, you have about like 3% of our CO2 waste products is going to be out here just dissolved in the bloodstream. This is just going to diffuse across. And then you got a certain amount, like 5%, is going to be in this carbonated hemoglobin form. So HbCO2. It's going to react together. You're going to get a hemoglobin molecule, and then you're going to get some CO2. But remember, a vast majority of your carbon dioxide waste is going to be in the form of carbonic acid, which is going to turn into a bicarb, yada yada. So we need to get rid of this bicarb ion. So O2 is out here, and the alveoli is just waiting to jump on. Okay, so we got oxygen plus that hydrogen ion with that hemoglobin, HHB. They're going to react together, and then we're going to get our carboxyhemoglobin. Okay, now this hydrogen ion out here, it's like, hey man, I need a job. H plus, and then our bicarb ion is going to come into the cell again, HCO3 minus, and then because our cells like to be charge balanced, this chloride ion is going to leave. It's like, see you later. Now we're going to form that carbonic acid again, H2CO3. And remember, there's only one hydrogen over here, so there's got to be another one coming from somewhere. Oh, hey, look. We got one right here, so it's going to combine together. And then, through carbonic anhydrase, CAH, we're going to get CO2 and H2O. And those are going to leave through the alveoli. That is gas exchange in a nutshell. And this is called the Haldane effect, where oxygen ditches or causes that hydrogen ion to ditch, forming that carbonic acid. Now, like I said in the previous slide, you don't need to know this, but I do at least want you to understand the fundamentals of gas exchange so you can at least understand how they're relevant to shock states. Okay, now let's do some review questions. So, a central venous catheter has been placed in a septic patient to monitor central venous oxygen saturation. Monitor reads at 88%. How should you interpret this finding in the context of septic shock? I will leave you with this one for a second. All right, so the answer is C. Now, I know that this is probably kind of confusing. I didn't actually write this one very well, but a high SVO2 or SCVO2 means that, like greater than 80%, means that the tissues can't eat. So sepsis can cause mitochondrial dysfunction, or like things like cyanide toxicity. The blood returns to the heart full of oxygen because the cells couldn't use it. So if this was less than 60, it means that the tissues were very hungry and that you should feed them. Okay. A patient presents with severe diabetic ketoacidosis and high fever. According to the oxyhemoglobin dissociation curve, these factors, acidosis, low pH, and a high temp, will cause the curve to shift in which direction? Did you guess B? It's B. See, told you. So according to the curve diagram, a decrease in pH, an increase in DPG, or an increase in temp causes a right shift. This is known as the Bohr effect, where oxygen is displaced from hemoglobin more easily, allowing for release into the tissues. Remember, the Bohr effect is all those hydrogen ions have to go somewhere, so they're going to knock that oxygen molecule off more easily. A patient in profound hemorrhagic shock has a drop in cardiac output. Initially, the tissues maintain metabolism by extracting more oxygen from the blood. However, the DO2, the supply, has now dropped below a critical threshold. What is the immediate metabolic consequence described in the text? Did you guess A? It's A. Remember, in profound shock, if delivery drops below that critical point, the tissues can't extract enough oxygen to survive, so they're always just going to shift into that anaerobic metabolism anyway. So, you want to try and avoid that because it's not good for you. So you don't have to sit around for another 45 minutes, I'm going to cut the video here, and then the next video will be kind of a review of the last 3 videos that I've put out, and we'll do like a small kind of review of everything that we've learned thus far. If you made it this far, I appreciate it. If you wouldn't mind subscribing, liking the video so I can please the algorithm gods, I would really appreciate it. If you want more content, please even do that again because it's motivating for me, and it makes me know that you actually appreciate the content that I am providing. That is all for me today. You guys have a good day. Study hard. Or don't. I can't control what you do with your life. But anyway, thank you for watching.